Hello, everyone. It's 1 o'clock, so we will start our webinar. And thank you very much for joining us today. My name is Sarah Wallace. I'm a consultant speech and language therapist at Wythenshawe Hospital in Manchester, specialising in critical care. And it gives me enormous pleasure to welcome you to our webinar on the impact of pharyngeal electrical stimulation on severe dysphagia and tracheostomy decannulation in the ICU. This is the first one actually in the UK, brought to you by the European Society of Swallowing Disorders, Phagenyx, and the National Tracheostomy Safety Project. So it's really exciting and a real honour for me to be joined by such an illustrious panel of speakers who I'm sure many of you are familiar with their incredible work. We have Professor Rena Sivas, Dr. Elmer Höfner, and Professor Brennan McGrath. And I'd like to thank them for their willingness to share their expertise today. We're recording the webinar for people who are unable to join us now. They can watch later at 7 p.m. and we know how busy everybody is. You will be able to put your questions in through the Q&A. Please use the Q&A. And we will be asking questions of each speaker following their presentation, and then hopefully time for a bit of panel discussion at the end. So just to start, we thought it would be helpful if I set the scene a little about dysphagia in ICU, just to explain a little bit of background to PES, and apologies to any of you already knowledgeable in this area. So we know that dysphagia during and following critical illness is very common and occurs as a result of a combination of factors such as ICU interventions like intubation, comorbidities, and of course illness severity, which all play a part in creating what's often a very multifactorial and complex dysphagia picture. And of course, most of the time this is an acute issue, but sometimes there is an underlying chronic problem, maybe not even previously assessed and detected, and that changes prognosis and changes our expectations around treatment benefit. Okay, next slide, please. So clearly we want to optimize swallowing outcomes in ICU, and in order to do that, we really need to assess really early both the sensory and the motor swallowing impairments, and that enables us to be targeted about our treatment approach. If we do that, we're hoping we can prevent chronicity and of course, respiratory complications, which obviously increase everything else in terms of length of stay in ICU. We obviously also want to expedite weaning and tracheostomy decannulation if we can manage the swallow efficiently, and you know, enabling patients to eat and drink sooner improves mood and overall functional outcome. Okay. So in terms of etiologies in dysphagia, these are your top 6 things to think about, really, from intubation trauma, which causes structural and sensory impairments, to patients who have a dysynchronous breath-swallow pattern as a result of being on respiratory support, invasive or non-invasive, and when they have got a respiratory disease or infection as well. And also neuromuscular weakness, which is obviously common in ICU patients, and as well as disuse, muscle atrophy, and neurological problems. Then we also have gastroesophageal reflux, which can create its own problems in terms of laryngeal mucosal injury, impaired cognition, which makes it unsafe for some patients to eat and drink, and sensory impairment, which I'm going to talk a little bit more about next. But we know that patients who've been intubated, for instance, have absent laryngeal adductor reflexes, and some of our patients have got cranial nerve injuries when they've had cardiothoracic surgery or head and neck surgery. So there's many things going on, often multiple things at the same time. Okay. So in terms of the sensory swallowing impairment, these can be peripheral or central or both. The presence of the ET tube itself alters the sensorium. We know that cough inflation and lack of airflow also affects sensory, laryngopharyngeal sensation, sorry. We know that silent aspiration is the most common form of aspiration in patients with tracheostomies. Sedatives themselves also are basically depressing laryngeal reflexes and are associated with silent aspiration. And then we've got neurological issues and laryngeal edema. Laryngeal edema has multiple causes, and it's often difficult to know what might be going on, but we know that that also interferes with sensation. And then critical illness and polyneuropathy. So much to think about that affects our sensation. Next slide, please. And on top of that, there are a number of factors which increase the dysphagia risk. We know a lot about the impact of durations of intubation, ventilation, and renal replacement therapies, and other patient medical issues such as diabetes, alcohol, ARDS that tend to create more long-term problems with swallowing. And tracheostomy is obviously a known risk factor for more long-term dysphagia. So it's absolutely key that we address these issues and treat the dysphagia. We also know that dysphagia is common in the adult population and increases in terms of risk with age, frailty, and neurological and respiratory comorbidities. So we have a lot of patients who decompensate when they're admitted to ICU and, may just need that treatment in order to expedite recovery. Next slide. So it's key we assess early. We start with a clinical swallow assessment in ICU. We tend to lean heavily on FEES, and FEES is really, really helpful in terms of informing patient selection for PES. It also, along with videofluoroscopy post-ICU, enables us to really be more accurate about how we measure treatment effect. And there are a whole raft of outcome measures that we can use to measure PES treatment effect. A few examples here. Next slide. So treatment options for dysphagia in ICU, I've tried to summarize roughly here, are around restoring airflow, swallow strength training, and then supportive strategies, and PES. And PES is really the most direct intervention that we can provide to improve the swallow physiology that is directed at the sensory impairment. So that leads me on to the following presentations, which we're going to talk about PES in more detail. So it's my great pleasure to introduce our first speaker, Professor Reinhard Sievers, and he is Professor of Neurology, Chairman of the Department of Neurology and Neurorehab at Klinikum Osnabrück in Germany. He's also Fellow of the European Stroke Association, President of the European Society of Swallowing Disorders, and Vice Chairman of the German Dysphagia Society. And he is going to talk about his research and experience using PES.
Dear friends, dear colleagues, my name is Reinhard Sievers, and I'm happy to contribute to this co-branded webinar of the European Society for Swallowing Disorders and Phagenyx. The title of my talk is An Introduction to Pharyngeal Electrical Stimulation. The swallowing network has a complex architecture. So we have cortical swallowing centers connected with the brainstem swallowing centers and the dorsolateral medulla oblongata. These are then targeting swallowing muscles by different cranial nerves. And apart from this downstream motor control, there is a constant sensory feedback provided to cortical and brainstem swallowing centers through different cranial nerves. Many diseases target the swallowing network at different levels, so there is stroke and TBI, causing lesions to cortical and brainstem swallowing sites. We have motor neuron disorders like amyotrophic lateral sclerosis, affecting the motor system, first and second motor neuron, Parkinson's disease, Guillain-Barré syndrome, and critical illness polyneuropathy, typically causing lesions to the cranial nerves, and then myopathies, myasthenia gravis, and critical illness myopathy, which affect the swallowing muscles itself. During recent years, innovative treatment options have been increasingly being researched. There is, for example, transcranial direct current stimulation, TDCS, and repetitive transcranial magnetic stimulation, RTMS, that both target the central swallowing network. In addition, we have neuromuscular electrical stimulation that stimulates peripheral, the swallowing muscles themselves. We have pharmacological agents that stimulate the mentioned sensory receptors within the pharynx and larynx, and finally pharyngeal electric stimulation, which is the key topic of this whole webinar. Here you see the stimulation device itself. It consists of two parts. This is the stimulation catheter that houses the stimulation electrodes in its wall. The stimulation catheter can be plugged into the base station, which allows you to determine the sensory threshold and the tolerance threshold. Stimulation is given per protocol for 3 consecutive days and 10 minutes each day. On the left side, you see how this works. So the catheter is placed, stimulation electrodes appear just above the upper esophageal sphincter. From here, stimulation reaches vagal efferents. The stimulation then reaches the brainstem swirling centers, the primary sensory cortex, and then spreads to secondary sensory cortices and also to the primary and secondary motor cortex. And from there, it modulates the downstream motor pathway. So how does pharyngeal electrical stimulation work? Back in the last century, Shane Hamdi, the inventor of this fascinating treatment, has already shown that after applying PES, there is a substantial and significant enlargement of the cortical representation of the pharyngeal muscles. Some years later, my group had shown that pharyngeal electrical stimulation modulates the cortical swallowing network, mainly leading to changes of the cortical representation of swallowing in the right hemisphere. In addition to this, of late, there are more and more indications that PES also has a peripheral effect on the swallowing system. So in this study, it was shown that PES leads to an increase of the secretion of substance P, a neurotransmitter intimately involved in the coordination of swallowing. And you see here that only after PES there was an increase in salivary substance P levels, whereas there was no increase in the sham condition and no increase of substance P levels in the blood. A later study focused on tracheostomy stroke patients with severe dysphagia, and this study could show that substance P levels rose in those patients, and these are marked in blue, that had a positive effect of stimulation, as opposed to those, and these are marked in red, that did not benefit or improve after pharyngeal electrical stimulation. The last study I like to mention here used a more complex design and studied the effect of PES and TDCS on a sensory disruption provided by xylocaine spray to the oropharynx and hypopharynx. Key result of this study, and time does not allow to go into more detail, was that PES indeed could revert the negative effects of this sensory afferent deprivation on cortical processing of both pharyngeal sensory stimuli and on overt swallowing. TDCS, on the other hand, was not able to influence the central network alterations resulting from this experimentally induced pharyngeal hyperesthesia. Apart from these data on brain physiology, there is some really robust clinical evidence in the support of pharyngeal electrical stimulation. The first milestone study is, of course, a fast-track trial which recruited tracheostomized and severely dysphagic stroke patients with randomized 1-to-1 to either PES or sham PES. Key result, primary endpoint in a nutshell, is given here. So PES sham stimulation, and in blue is the part of the population that responded to stimulation and was ready for decannulation after the study intervention. And you see here, this was nearly 50% in the study group and below 10% in the sham group, and the difference was, of course, highly significant. Interestingly, this effect size given here was in close match with that of a previous pilot study recruiting a lower number of participants. But the similarity of both results really induced confidence into this treatment effect. The second large trial to date is the FADA Registry, which was a phase 4 trial, prospective but non-randomized, recruiting 4 types of patients: non-ventilated stroke victims with a period of ventilation, non-stroke patients with a period of ventilation, and patients with traumatic brain injury. Again, in the interest of time, primary endpoint very briefly given here. So change from baseline in the dysphagia severity rating scale was obvious for all 4 patient groups, and swallowing function improved from day 5 to day 9 to 3 months. Remarkably, also patients with infratentorial stroke, as opposed to those with supratentorial stroke, benefited from this type of stimulation. This is very important because patients with infratentorial stroke did not participate in the fast-track trial. Due to these really promising results, PES is today mentioned in different guidelines. For example, in the guidelines of the German Society of Neurology, which in fact is also endorsed by many other societies, as you can see here. Also, European Society for Swallowing Disorders, the German Dysphagia Society, and also different rehab societies in Germany, Austria, and Switzerland. In addition, PES is recommended in the guidelines of the European Stroke Organization, together with the European Society for Swallowing Disorders, and of late also in the National Clinical Guidelines for Stroke from the UK. So, in conclusion, I've shown you that PES facilitates cortical plasticity and release of substance P from peripheral laryngeal nerves. PES reverses a virtual lesion of the peripheral sensory system. The fast-track trial, which was a randomized control trial, showed that PES effectively treats dysphagia in tracheostomized stroke patients. The FADA registry, which was a phase 4 trial, showed that PES improves swallowing functions in different cohorts of dysphagic patients. And finally, I referred to different guidelines that today recommend the application of PES. So I'd like to thank you for your attention, and I'm open to your questions either now or later by email. Thanks.
That's wonderful. Thank you, Rainer. And thank you for joining us also from Frankfurt. I know you've got to go and won't be able to stay for the panel. So I have a few questions that have come in that we can ask you now, if that's okay. So the research is really clear, I think, around the neurological cohorts. And then we have some non-ICU populations in the study that you mentioned. I wondered if you could just talk a little bit more about the evidence in the non-neuro patients and the sustained benefit.
Yeah, thank you, Sarah. I think what we learned so far is that PES seems to work best if there is a problem in the sensory system. And apart from the neurological cohorts we so far studied. I believe that PES may really work best because of this in patients on the ICU post-extubation. So I know that parts of the FADA cohort were indeed these patients, and I am pretty sure that we will hear about these cohorts later from Elmar. But this is at the moment my gut feeling. So with PES, you either go for stroke and tracheostomized patients, or you go for post-extubation dysphagia, or simply tracheostomized ICU patients with another underlying disease apart from stroke. This is at the moment my gut feeling that this will be the future.
That's amazing. I mean, and that's what we're all hoping, I think, because that's, you know, what a lot of people are working in ICUs with non-neuro patients. Right. So do you think the benefits are sustained in the same way in the non-neuro patients, to the point where often the dysphagia, as they can decannulate, you know, usually resolves? So do you think that this has the same benefits?
Yeah, I of course, we can't be sure at the moment, but I really believe and hope that we will see this. So the important thing with PES is that you really try to restart the swallowing system. And if this has happened, then the patient is open for other types of dysphagia therapy, behavioral swallowing interventions in particular. And this is true for stroke, but also for non-stroke etiologies. So, for example, in post-extubation dysphagia, you improve the sensory system, the sensory feedback, and thereafter the patient will have a safer swallow and is then able to tolerate and participate in other swallowing interventions and will benefit from them, which would not have been possible without the preceding PES treatment. So yes, I do believe that we will see a sustained effect of PES in these patients.
And that kick-starting the swallow is, as you say, then sort of expedites recovery in so many ways, and that's certainly what I see. Do you have any comments on that, Elmar or Brendan, from what you've seen?
I think especially the point Rainer said is that it opens up possibilities to further improve swallowing later with other methods. So starting up the swallowing function first with PES and then continuing with traditional methods is, I think, quite a common way we use now, and this is exactly the point.
Yeah. Any comments, Brendan?
Yeah, just on a sort of per patient basis. I mean, we obviously use PES quite a bit in our general intensive care service, and even though we might not get the patients decannulated or get them back onto a full meal straight away, we can get to the point where they can maybe manage their secretions better, which might mean they get the cuff down on the tracheostomy, which then progresses other aspects of their care. So the improvement can be quite dramatic, but it usually does something which can progress the care. That's our experience.
That's amazing. I think one more question that I'd like to put to you while we still have you, Rainer, is around what are your recommendations around measuring treatment effect? Is it just about progressing to earlier decannulation, or what sort of things do you suggest we use to measure treatment effect?
Yeah, as you said in your wonderful introduction, you already emphasized that doing instrumental assessment in these patients is of critical importance. So what I suggest after each cycle of PES, do a proper FEES study in the patient, assess what treatment effects were there or which were lacking and you hoped for but did not achieve, and based on this consider what treatment steps should follow. So it's really crucial to have a proper FEES service installed in your unit when you start to work with PES, because otherwise you really can't observe the full benefits this treatment is providing to the patients.
And I think it's important that we try to prove the benefit often, that we're trying to secure funding for treatment services like this. So we need to use outcome measures. Are there any ones that you think, Elmar, are important, or Brendan? Anything else to add? Well, maybe we'll come back a bit more to that at the end. But Rainer, we're very appreciative of your time. Thank you so much for sharing your incredible research. And if more questions come in, we may ask you to respond to those later. So thank you very much indeed.
Thanks for inviting me. Have a great evening.
Bye-bye. We will move on. So it's now my honor to properly introduce Dr. Elmar Höfner. He is a senior physician in the Department of Neurology in Klagenfurt Hospital, which is one of the world's leading sites in PES. And he's an expert in neurogenic dysphagia and has implemented PES as standard of care now in his hospital. And he's now going to talk about that.
Dear ladies and gentlemen, it's a great pleasure and honor to speak to you today in this webinar. Thank you for having me. I will be discussing pharyngeal electrical stimulation in various clinical settings within neurology and sharing how we implement it here in the south of Austria. A quick note on my disclosures. I'm not receiving any compensation for what I'm about to share, nor do I have any financial ties with Phagenyx Limited. In other words, I'm doing this purely for good karma. I'd like to begin by briefly introducing my hospital to provide you with a sense of our working surrounding. The regional hospital Klagenfurt, also known as Klinikum Klagenfurt, serves a region with 650,000 inhabitants. The region also attracts 2.9 million visitors annually. While we are formally classified as a secondary care hospital, we pride ourselves on being Austria's third largest hospital. We offer a wide range of services, with the exception of organ transplantations, and while we have an academic affiliation as a teaching hospital, we are not a university clinic. My department, the Department of Neurology, boasts a stroke unit and an intermediate care unit for acute rehabilitation. We are also, shall we say, endued with a dedicated neurological ICU, highlighting its special role in our care. In total, all across the wards, we have 90 beds. Annually, we provide inpatient care to 2,500 patients across these beds. Approximately 700 of these are treated in our stroke unit and around 200 are cared for in our ICU. The anesthesiological department at our hospital manages a sizable ICU complex with 30 fully equipped critical care beds. In 2015, colleagues approached us due to concerns about post-intubation dysphagia, suggesting an interdisciplinary collaboration. This collaboration birthed an interdisciplinary team for neurogenic dysphagia that same year, comprising SLTs, anesthetists, and neurologists. We began training in fibroendoscopic evaluation of swallowing, commonly known as PES, and subsequently obtained certifications. It was during this period that we were introduced to pharyngeal electrical stimulation, which directly addressed our primary concern. In Austria, PES is typically performed by doctors. However, the volume of PES required surpassed our doctors' capacity. To address this and improve workload distribution, we established an in-house policy allowing our SLTs to conduct PES. This not only provided easier access to dysphagia diagnostics, but also offered legal assurance to our SLTs. As we deepened our understanding of dysphagia and its associated challenges, our team's expertise and acceptance grew. We strictly limited ourselves to neurogenic dysphagia to avoid overstepping our boundaries and encroaching on the domain of our ENT colleagues. In terms of underlying conditions, we primarily treat patients with strokes, both hemorrhagic and ischemic, inflammatory CNS diseases such as meningitis, encephalitis, and vasculitis, as well as those with traumatic brain injuries, acute neuropathies like Guillain-Barré syndrome, and patients who have undergone long-term intubation for various reasons. What lies at the heart of the issue? The daily cost for a single ICU bed ranges from 3,000 to 3,500 euro, and there's a significant demand for hospital beds, particularly ICU beds. In German, we refer to this as Bettendruck. While primary weaning can be challenging, it's especially so with neurological diseases. Transferring patients to the ward often becomes problematic due to dysphagia, which in turn necessitates the use of a tracheal cannula, further complicating care and, of course, reducing quality of life. Pharyngeal electrical stimulation in the ICU setting can sometimes be challenging. However, we anticipate improvements in dysphagia and a reduction in reintubations. Additionally, we hope to see a decrease in the length of stay and tracheostomy rates. What criteria do we use to select patients for pharyngeal electrical stimulations in the ICU? Firstly, the patient's sedation has either been discontinued or is maintained at a minimal level. The patient begins to show signs of responsiveness, but may have oral pooling of saliva, lack adequate swallowing movements, or may not attempt to swallow at all. Additionally, pharyngeal sensory impairment can be an indication for stimulation. Sensory disorders might be unilateral, as seen in strokes, or bilateral, as observed in conditions like neuropathies or following long-term intubation. Some of the selected patients may still be intubated, while most have been recently extubated or already possess a tracheostomy. Typically, we switch to tracheostomy after 10 to 14 days of intubation. We are all aware of the prevalent dysphagia rates in acute stroke patients, with literature citing figures up to 70 or 80%. Our engagement with dysphagia and the establishment of a dedicated team led to the creation of an early dysphagia screening program on the stroke unit. Here, nurses conduct an initial pre-screening upon admission, and SLTs intervene as required. As previously mentioned, our stroke unit experiences high patient turnover, with 700 patients annually and only 6 stroke beds, and of course no bed sharing. The duration of stay on the stroke unit tends to be brief. Consequently, we don't administer stimulation to many patients in our stroke unit. However, this scenario might differ in other hospitals based on their organizational structure and resources. The situation on the acute rehab ward and the IMC is fundamentally different. While many patients have tracheostomies and are mostly stable in terms of respiration, their swallowing can be severely impaired. We administer stimulation in the post-acute phase following the initial incident, which can range from several days to weeks, and in some cases even months later. Our primary goal is to facilitate tracheostomy weaning. For certain patients, we administer a second round of stimulation for an additional 5 to 7 days, and in some instances even consider a third round. We've learned from colleagues at the German rehab clinic that they sometimes conduct 5 to 7 rounds of stimulation, or even more. Patients in our neurological wards are typically either not as severely impaired or at least stable in terms of vital signs. For some, dysphagia can be the predominant symptom. In all of these cases, pharyngeal electrical stimulation shall not replace the SLT, but serves as a complement to standard logopedic treatment methods. In addition to the conditions previously mentioned, we also use electrical stimulation for neurodegenerative and or autoimmune diseases, such as Parkinson's or MS. The number of stimulations has increased over the past years, as depicted in this diagram. We began tracking in 2019, and in recent years we have performed between 50 to 55 stimulations annually, despite the challenges of COVID and their familiar restrictions. The notable decrease in stimulations on the wards between 2021 and 2022 resulted from bed reductions due to both COVID and the nursing shortage. The majority of stimulated patients breathe through their natural airway, yet approximately a third have tracheal cannula. Since we initiate stimulation early, anticipating enhanced efficacy, a significant number of patients are still intubated with an endotracheal tube. To ensure optimal patient selection, we established a SOP. As previously mentioned, our focus is on neurogenic dysphagia. Before proceeding with stimulation, a FES must demonstrate reduced pharyngeal or laryngeal sensitivity, penetration, aspiration, or significant retentions, particularly on the posterior pharyngeal wall, indicating weak muscular contraction. A delayed swallowing reflex might also be an indication for stimulation. We consider the placement of the stimulation tube if 3 consecutive days of standard therapy result in an unexplained lack of progress. By unexplained, we mean factors not attributable to sedation, infection, medication, seizures, or similar causes. How about outpatient treatment? I believe pharyngeal electrical stimulation in an acute day ward or outpatient department is entirely feasible. However, in Austria, the issue of health insurance coverage for this treatment hasn't been fully addressed. This also holds true for treatments provided by practice-based physicians. In essence, while it seems like a viable option to me, it is not yet covered by health insurance. Ladies and gentlemen, before I conclude, I'd like to express my heartfelt gratitude for all of you for your attention and engagement. A special thanks goes to my dedicated dysphagia team, whose unwavering commitment and expertise have been instrumental in our achievements. It's been a privilege to share our experiences and insights with you today. As we wrap up, I'd like to leave you with a glimpse of the beautiful region I'm privileged to work in. In the distance, you can see the city of Klagenfurt, where all the work I've shared with you today takes place. If you ever find yourself wanting to visit and see our practices firsthand, just follow the arrow. And for those who prefer the digital realm, simply scan the QR code to explore our hospital's website. We'd be delighted to welcome you, whether in person or online. Thank you for having me, and I hope our paths cross again in the future. Stay safe and take care.
Wow, thank you so much, Elmar. Both very inspiring what you've achieved, but also, you know, Klagenfurt looks very beautiful. I might take you up on your offer to come and visit. But
welcome.
very, very inspiring how you've developed PES and facilitated speech therapy and FES, and you're just trying so many things that I hadn't thought of, like with PD patients. We've had a couple of questions come in, which, if I may, one is about laryngeal edema and whether you know, we know this is really common in the ICU cohort for, you know, numerous reasons, but do you find that that's a limiting factor ever?
No, not at all. No, not at all. I think if I start stimulation, if I can induce some swallowing movements, I think I would reduce the edema further.
I agree. Brendan, anything to add?
No, only that, I mean, laryngeal edema shouldn't stop you placing a catheter, and you know, you've usually seen laryngeal edema because you put a camera up there in the first place, so you know, you get a good idea of the anatomy. So placement of the catheter shouldn't be a problem. And then, as you've both already said, often the treatment does lead to improvements in secretion management. Swallowing may then allow us to take down tracheostomy cuffs, for example, which are all therapies or all treatments that are likely to then further reduce that edema. So I would see PES, it doesn't guarantee it's going to fix edema, but I certainly don't see it contraindicated, and I would expect it would help.
Yeah, that's great. I was wondering as well what you said, Elmar, about the number of rounds of treatment that you were talking about, and how some people are even trying up to 7 rounds of treatment. I guess my question is, how do you decide when to do another round? And do you think there's any limit to how many times? I guess patient tolerance is one factor, but what are your thoughts on that?
Well, we haven't exceeded 3 rounds yet. So the colleagues from Bavaria who told us they use 5 to 7 rounds, it really surprised us. But they think it still improves swallowing.
Right.
I'm not entirely sure about it, and it's difficult to say who to choose for another round. But sometimes, especially if we had patients who were in a worse neurological state at the beginning when they received the first round, and they improved later on, and a few weeks later we decide, okay, they had some progress, but now they don't improve further. We should try a second round, and so it depends on the patient, I think.
Yeah, I can understand that. I'm just wondering, do you need a bit of a delay then in order to allow for any lag in treatment effect? Do you think that's important?
My clinical experience is that the biggest impact is to be seen after a few days after stimulation, not immediately during stimulation. So I would at least wait 1 or 2 weeks before starting another round.
Okay, that's good to know. I mean, I think I've certainly seen in some patients an immediate kind of response in that they go from not swallowing at all to starting to swallow. But in terms of making real functional changes to swallow, it may take a bit more time, as you say. But that's really, really helpful to know. I think we'll move on now to our last presentation, and we will come back with some more questions at the end, Elmer, if that's okay. Thank you again so much. So it's now my absolute pleasure to introduce Professor Brendan McGrath. Brendan is Honorary Professor at the University of Manchester. He's consultant anaesthetist intensivist at Wythenshawe Hospital and NHS England National Clinical Advisor for Tracheostomy, European lead for the Global Tracheostomy Collaborative, and founder and chair of the National Tracheostomy Safety Project. So Brendan is going to talk to us about our experience of PES at Wythenshawe.
Hello, and thank you for the introduction. I'm going to talk about some real-world experience on pharyngeal electrical stimulation from our hospital in Manchester in the centre of the United Kingdom. So I see dysphagia in the critically ill as very multifactorial. PES definitely has a role in the treatment of dysphagia of any etiology, and our cohort who required PES therapy have usually got tracheostomies, and we certainly see a role for improving laryngeal function in this patient cohort. So what I'll aim to do in the next 10 minutes is to describe our services for identification of dysphagia and how we manage patients in our recovering critically ill cohort. I want to describe the severity and the progression of dysphagia in our patients and how we manage that with repeated fees and clinical assessment, and then describe the impact of PES therapy as a therapeutic option for severe dysphagia in a cohort of our patients. So our service is in Manchester in the United Kingdom. It's normally not as sunny as that at our hospital. It's built on an old TB sanitarium, and this photograph is from the 1800s, which show the south-facing sunny windows, which was pretty much all the treatment that we could offer our patients back in the day. Things have improved a little bit. We now have a 900-bed tertiary centre with a major cardiac and respiratory caseload, and we focus on delivering ECMO and transplant services, as well as the full range of general critical care services. To give you an idea of the size of the hospital, we have 17 general ICU beds, 3 burns beds, and around 40 cardiothoracic ICU beds. We also have embedded speech and language therapy sessions in our ICU, and I know we're very lucky to have Sarah and her colleagues who come to the bedside on a daily basis in the intensive care unit and get involved in the management of our complex patients. And here's Sarah performing a fees examination in one of our tracheostomy ventilator patients who's wide awake, and as you can see, he's enjoying watching what's happening on the TV screen. So we're lucky to have a fantastic speech and language therapy service, and I know other centres are jealous of what we've got. In terms of what happens to trigger a referral to the speech and language therapists, it's typically anyone with a tracheostomy, any patient who's got dysphonia, and any concerns around dysphagia clinically at the bedside, usually raised by the nursing staff. Our indications for fees typically are suspicion of laryngeal injury, any obvious reflux or regurgitation, excessive secretions, severe dysphagia that's clinically apparent, any suspicion of aspiration, and any patient that doesn't tolerate cuff deflation or insertion of a one-way speaking valve with their tracheostomy. We define severe dysphagia when we look with the scope, and any significant sensory impairment that we detect on fees, any silent aspiration, any lack of response to secretions in the larynx, any lack of response to residue, or lack of response to the placement of the scope into the larynx, all imply severe dysphagia. We use the penetration aspiration clinical severity scale to grade and to track the severity of dysphagia. And this is a scale from 1 to 8 with scores of 6, 7 and 8 being the most severe categories, and usually that means the patient will be nil by mouth. Our indications for PES therapy are fairly standard. We originally restricted PES therapy to patients in the intensive care units, but now Sarah and her colleagues are performing PES therapy out on our wards as well. You need a calm and cooperative patient because you need to be able to obey commands and understand what's going on. But importantly, you need provision of the speech and language therapists who are trained in the use of PES therapy. And we need to be able to perform a FEES at the beginning and at the end of treatment and be available for every day to provide that treatment. And that can be a stumbling block in having availability of trained staff. It happens at our hospital, I'm sure that happens elsewhere as well. Fairly standard exclusions, so patient refusal if the patient needs an MRI scan in the interim. Obviously that's not compatible with the nasogastric tube and the PES therapy. Any patients with implantable devices such as pacemakers, defibrillators, clinical instability or delirium, which is unfortunately quite common in our ICU patients. So we're going to look in detail at this cohort over a 5-year period between the summers of 2017 and 2022. 574 patients underwent FEES. Of this group, 132 patients were defined as having severe dysphagia with a PENAS score of 6, 7 or 8. 19 of these patients were offered a course of PES therapy with the indications as they were presented on the previous slide. 18 of these 19 patients had a paired FEES before and at the end of therapy. Unfortunately, one of the patients died due to progression of their critical illness. And the vast majority, 17 of these 19 patients, had a tracheostomy at the time of PES treatment. And that just reflects our service in the intensive care unit, where we've got severely ill patients that usually need a tracheostomy as part of their recovery. You can see the split of base specialties and the problems that our patients had, dominated by the cardiothoracic and respiratory specialties that we have that dominate our critical care units. For our PES cohort, the mean age was 64.5 years with a range of 43 up to 89 years old. Very representative problems, as you've seen on the previous slide. We undertook FEES and then PES therapy in these patients who required a prolonged wean from mechanical ventilation. So it was typically about 41 days from ICU admission to the start of therapy, which meant about 23 days from the insertion of the tracheostomy to the start of PES therapy. And if we look at this graphically, we've got 5 days typically the patients from admission to hospital to admission to ICU. Then we had a 7-day period where the patients were ventilated on the ICU with an oral translaryngeal endotracheal tube. This is followed by tracheostomy, and typically it was 10 days after tracheostomy until we considered the patient for PES therapy. And that's usually the time taken for them to recover and for us to identify that they do in fact have severe dysphagia. Typically the tracheostomy was in place for around 20 days, and during this window this is when the PES therapy occurred. And then our patients, once they were discharged from the ICU, were typically in hospital for the further 3 weeks. So that's our typical course that I'm going to describe in detail for our cohort of patients that had PES therapy. So you can see we were undertaking PES therapy relatively late in the patient's hospital and intensive care stay. Most of our patients had 4 treatments, which is slightly more than the typical 3 treatments, and this was dictated by usually seeing some improvement, but a sense that we could get more improvement from the patients. We recorded the threshold and the maximum currents that patients were tolerating, and you can see here the values in terms of milliamps are fairly typical for what you'd expect for PES therapy. If you look at the penetration aspiration scores after the PES treatment, the blue circles represent the starting points for our patients before the PES therapy. And you can see the vast majority of these patients had a PES score of 8, which is the worst category. There's only one person with a PES score of 7. Now, 11 of our patients improved their scores following PES therapy. And this is within around 7 to 10 days of therapy. Their PES scores improved, often quite dramatically. And you can see there's a group of patients there whose PES scores improved from what we would consider to be unsafe with a high aspiration risk into risks that were moderate or considered safe. So we were improving patients quite significantly. So around 60% of patients improved their dysphagia when we judged it with PES therapy. If we look at the International Dysphagia Diet Standardization Initiative, the IDDSI scores, you can see our patients started in the middle in this grey band where they were often nil by mouth. And if you look at the changes in scores above the line, this is for food, so you can see that patients went from nil by mouth to be able to eat pureed, minced and moist, soft and bite-sized food, or often regular food intake. The changes below the line represent fluid, and you can see that patients improved to extremely thick, moderately thick, mildly thick, or thin, all the way through to normal fluids. And again, you can see that most of our patients were improving their oral intake, usually going from nil by mouth up to eating and drinking sometimes regular foods. So how does that compare to our non-PES cohorts? This is the group of patients that had all the other therapies available to them and all the other care that we would deliver for our recovering tracheostomized patients who've got severe dysphagia. Well, when we compared the groups to see if they were the same, and essentially our PES cohort was very similar in terms of illness severity judged by Apache 2 score, and the other metrics of severity of illness were very similar. So in terms of time on ventilator, time receiving advanced cardiac support, time receiving renal support and gastrointestinal support, all of these were the same. If you look at the number of ICU days, the patients that we selected for PES therapy actually took more ICU days than our non-PES therapy. And I think that represented the fact that we were looking at the most severe end of the spectrum. If you look at the recovery over time, you can see that I've put some regression lines on here to try and show you what was going on. So if we look at this simplified slide, you can see that the non-PES group improved by a mean difference of 1.68 on the penetration aspiration scale. This is compared to the PES group that improved by 2 points. But what you'll see is that the improvement in the PES group was more significant, but it also occurred earlier because the time taken for our non-therapy cohort to improve was significantly longer. But if we put that into context and think about a typical patient journey, I'm going to tell you about one of our patients who was critically ill, who met colleagues who put him off to sleep. He spent a long time on the ICU and he had a profound critical illness myopathy. And this meant he was also severely dysphagic when we looked. So he was ventilator dependent and we embarked on some PES therapy. And you can see from the picture that despite him still being peripherally weak and still being stuck on a ventilator, he's able to eat and drink. He had better secretion control, which meant he was able to swallow, able to cough, and we're able to get his tracheostomy cuff down, which meant he could vocalise. So we eventually got this patient decannulated. But what I wanted to highlight is that PES therapy in this situation didn't result in any miraculous reduction in dysphagia and any sudden liberation from ventilation or from tracheostomy, but it did help improve this patient's experience. We got him eating, drinking and talking and eventually got him decannulated, and I think that was in part due to the PES therapy. Now if we'd have done that PES therapy earlier, perhaps that would have meant an early recovery. We don't know. But in summary, I think it's clear that PES therapy improves dysphagia in the critically ill. We have been using it relatively late in the patient journey when we've identified dysphagia in our recovering critically ill patients. But I think there's clear signals for faster and greater improvements than if we just use our standard interventions. So the questions I've got is, should we be using PES therapy earlier, and should we be using it in more of our patients? And I think as data emerges, hopefully we'll get some answers to these important questions. Thank you for listening.
Thank you very much, Brendan. It's fantastic to hear you talk about our data, and I like your last question. I think that's probably where we need to start this final discussion. Should we be using PES earlier, and what are the barriers, do you think, in your experience and in your experience, Elmer, as well, to using it more and sooner?
Well, I think, as hopefully I've highlighted on some of those slides there, we tend to recognise dysphagia quite late, and because the therapy is relatively new and I suppose relatively expensive in some sort of costings. We're waiting to diagnose dysphagia before we intervene, and I think the patients that that you FEES and your team FEES, Sarah, and we go, oh, they're dysphagic. It's not a surprise. We could have predicted it a lot of times. And so, yeah, I think we'd be tempted to do it earlier. It's good to have the FEES, which sort of characterises it. But I'd like to see the study one day that does PES early and sees if we can reduce either the impact or the severity of dysphagia in our patients. Don't know if you've got any thoughts on that, Alma.
I think so too, because I think the earlier we start with stimulation, the more impact has the therapy itself. I think we can even prevent some complications which would occur due to the dysphagia if we already start improving the sensitivity of the pharynx early. And in some selected patients, we even do stimulation with an endotracheal tube still in place, because we expect it from the pattern of neurologic damage in the brain. So sometimes we know this patient will be dysphagic. So why should we wait longer?
I think that's fascinating. Honestly, I think delirium for us is a big barrier. And if we don't, I'm interested to know, Elmer, how you practically carry out PES in terms of setting thresholds for patients where we traditionally would want a little bit of patient cooperation. How do you determine treatment thresholds? How do you observe the benefit, I suppose?
We look at vegetative reactions. We look at some signs of pain the patient might feel from the test stimulation, and then we stick to the usual thresholds, and we don't go over the 50 millivolts, which are recommended.
Right. So very cool.
It's not difficult, actually, because even if a patient is non-responsive, you can see the heart frequency go up, or the blood pressure go up, or the patient moaning or beginning to move a little bit, or show signs of uncomfortableness. And these are the signs we're looking for if he can't tell us that it's strong enough, and then we reduce it to the adequate level and use that threshold as a stimulation voltage.
That's really interesting, because one of the signs, obviously, that we look for is swallowing as a response to treatment, and obviously that's not something you can use when they are intubated. I think it's a completely different way of thinking, isn't it? But clearly, as you say, if we can prevent that loss of sensation, we can maintain and preserve swallowing. Then we might not need to do it later. You might do speech therapy out of a job completely.
Maybe one day we put in the tube together with the stimulation tube.
Yeah, why not? I'm reluctantly, I think, going to have to bring the webinar to a close. So I hope everyone's enjoyed it as much as I have, and I've learned a lot. And I would really like to express my appreciation to Professor Sivas, Elmer and Brendan and to ESSD and Phagenyx and NTSB, and to thank you. And if you have any questions, burning questions, please do send them in and we will try and address them by email later. So thank you again and goodbye and take care.